What if almost everything you think you know about medicine and hygiene in the Middle Ages is wrong, and the version you know was invented by people who needed the Middle Ages to be dirty so they could feel clean by comparison? The popular image of medieval life as a permanent condition of filth, ignorance, and superstitious brutality is one of the most durable myths in popular history, and it is substantially wrong. Tonight, I am here with Rowan Hartsteele.
Good evening, Clara.
Medieval medicine was limited and often based on incorrect theories, but it was not simply absurd, and the people who practiced it were not simply ignorant. They were working with the intellectual tools available to them, and some of those tools worked. Tonight we turn to a period in history that has been systematically caricatured, and to the question of what medieval people actually knew, what they actually did, and why the myth of the Dark Ages was so useful to the people who invented it. The question is not whether medieval medicine was good medicine by modern standards, but what it actually was, and why the distance between the reality and the myth matters for how we understand history.
The real weakness of medieval medicine was not stupidity or superstition. It was the absence of germ theory, antibiotics, modern anesthesia, and reliable sterilization. These absences made medicine genuinely dangerous and often ineffective. But they are very different from the caricature of medieval healers as witless practitioners of pure magic and prayer.
We are speaking about medieval medicine, medieval hygiene, and the myths that have distorted our understanding of 1,000 years of human history.
The myths were not accidental. They were constructed, and understanding who constructed them, and why is as important as understanding what medieval medicine actually was.
Then let us begin with the myth itself, and with who needed it to be true.
The image of the Middle Ages as a period of darkness, filth and ignorance was largely constructed by Renaissance and Enlightenment writers who needed a contrast to define themselves against. If you want to argue that your own era is characterized by reason, progress, and civilized refinement, it helps enormously to have a preceding era that was characterized by irrationality, squalor, and barbarism. The medieval period was cast as that preceding era, and the casting was not entirely faithful to the evidence. The myth of universal medieval filth is perhaps the most persistent. The idea that nobody bathed in the Middle Ages, that people lived in permanent unwashed squalor, has been repeated so often that it feels like established fact. It is not. Public bathhouses existed in most medieval European cities of any size. London had bathhouses called stews throughout the medieval period. Paris had them. Records from numerous medieval cities document regular bathing practices, bathing on Saturdays before Sunday worship, and the existence of bathing as a recognized social activity.
So public bathing was a normal part of medieval urban life, not an exotic exception.
Yes, and here is the first thing we need to correct about the standard account. The decline of public bathing in early modern Europe was partly associated with the spread of syphilis in the late 15th and early 16th centuries, which was linked to bathhouses as sites of sexual contact. Ironically, it was the period immediately after the medieval era that saw a significant reduction in public bathing culture in parts of Europe. The dirty Middle Ages myth has the chronology almost exactly reversed. Medieval medical theory was built primarily on the inheritance of ancient Greek medicine, particularly the framework of the four humours: blood, phlegm, yellow bile, and black bile. Health was understood as the balance of these four substances, and illness as an imbalance. Treatments were designed to restore balance, typically through diet, herbal remedies, bleeding, or purging. The theory was wrong in its fundamental assumptions about how the body worked, but it was a systematic, internally consistent framework that organized observation and treatment in ways that were not purely random.
So humoral medicine was a coherent system, even though its underlying model was incorrect.
Yes, and this matters for how we assess medieval practitioners. A physician working within the humoral framework was not simply making things up. He was applying a received theoretical system, observing results, and adjusting treatments based on what he saw. The system pointed him in wrong directions frequently. But it was not the absence of reasoning. It was reasoning applied to an incorrect model. Some medieval treatments were effective, even though the explanations for why they worked were incorrect. Honey was used on wounds and wound infections throughout the medieval period. Honey is genuinely antimicrobial. Its low water content, acidic pH, and hydrogen peroxide content create conditions hostile to bacterial growth. Medieval practitioners did not know any of this. They used honey because observation showed it worked. The mechanism they would have proposed was entirely wrong. The effect was real,
So, empirical observation could produce correct practices, even when the theoretical explanation was wrong.
Exactly. Willow bark was used for pain and fever throughout the ancient and medieval worlds. It contains salicin, which the body converts to salicylic acid, the active compound in aspirin. Wine and vinegar were used to clean wounds, and both have genuine antiseptic properties. Maggot therapy, the application of fly larvae to necrotic wounds, was documented in medieval contexts, and is now used in modern medicine because the larvae consume dead tissue without harming living tissue. These were not sophisticated treatments by modern standards, but they were not simply superstition. Uroscopy, the examination of urine for diagnostic purposes, was one of the most widely practiced diagnostic techniques of the medieval period. Physicians examined the color, clarity, smell, and consistency of urine and drew conclusions about the patient's condition. The technique was partly useful, partly unreliable, and partly theatrical. Pale or cloudy urine can genuinely indicate kidney or urinary conditions. Urine color can reflect hydration and some diseases, but uroscopy was also extended to claims that went well beyond what urine observation can actually support, and it became a target for satire and fraud.
So, uroscopy was simultaneously a partially valid diagnostic tool and a widely abused one.
Yes, and this combination, a real technique extended beyond its valid range by practitioners who could not distinguish its limits, is characteristic of pre-scientific medicine generally. The problem was not the absence of observation. It was the absence of controlled methods for determining which observations were meaningful and which were coincidental. The role of monasteries in preserving and transmitting medical knowledge was crucial. Benedictine monasteries operated hospitals, maintained herb gardens, and copied ancient medical texts. The rule of Saint Benedict required care for the sick as a religious duty. Monastic communities were often the most medically competent institutions available in early medieval Europe, not because monks were trained physicians in the modern sense, but because they had access to written knowledge, to botanical resources, and to the organizational capacity to provide sustained care. The Islamic medical tradition made contributions to medieval European medicine that are often overlooked in popular accounts. Physicians like Ibn Sina, known in the West as Avicenna, and Ibn Rushd, known as Averroes, produced systematic medical encyclopedias that synthesized and extended Greek medicine with new clinical observation. Ibn Sina's Canon of Medicine became a standard text in European medical education for centuries after it was translated into Latin. The later medieval medical revival in Europe drew heavily on translations of Arabic medical texts.
So medieval European medicine was not isolated from the wider world. It was in active dialogue with Islamic scholarship.
Yes, and the translation movement of the 12th and 13th centuries centered particularly in Toledo and Sicily, where Latin, Arabic, Greek, and Hebrew scholarship intersected, brought an enormous body of medical knowledge into European universities. The medical school at Salerno in southern Italy, the earliest major European center of medical education, drew on this multilingual, multicultural inheritance. Medieval European medicine at its most developed was not a closed or static system. The Black Death of 1347 to 1351 was the most devastating epidemic in European history, killing perhaps a third to a half of the population of Europe within a few years. The response to it included practices that look recognizable from a modern public health perspective. Venice introduced a 40-day isolation period for ships arriving from plague-infected ports, from which the word quarantine derives, quarantina meaning 40 days in Italian. Cities attempted to isolate the sick, remove the bodies of those who had passed away, and restrict movement.
So quarantina as a public health concept was invented during the medieval response to the Black Death.
Yes. The reasoning behind quarantine was not based on germ theory, which did not exist. Medieval thinkers attributed plague to miasma, bad air arising from decaying matter, or to astrological configurations, or to divine punishment. But the practice of isolating the sick and restricting contact between infected and uninfected populations was empirically correct. Even though the theoretical justification was wrong, observation had revealed that proximity to the sick increased the risk of becoming sick, even before anyone understood why. The distinction between learned medicine and popular medicine in the medieval period is important and often collapsed in popular accounts. University-trained physicians who existed from the 12th and 13th centuries onward at institutions like Bologna, Montpellier, and Oxford practiced a theoretical medicine rooted in Galenic and Arabic texts. They were a small and expensive elite. The vast majority of medieval people who sought medical help consulted barber surgeons, herbalists, midwives, cunning folk, apothecaries, and local healers, whose knowledge was practical, empirical, and transmitted through apprenticeship rather than texts.
So medieval medicine was not one thing but many things operating at different levels of society.
Yes, and the popular healers who served most of the population often had genuine practical knowledge of plants, wound care, childbirth and common ailments that was not inferior to university medicine in its outcomes, and was frequently more accessible. Midwives in particular possessed accumulated practical knowledge of obstetrics that university medicine, which largely excluded women from formal training, did not match in practice. The medieval hospital is another institution that the popular image of the Middle Ages significantly underrepresents. Hospitals existed in most substantial medieval European cities, typically founded and operated by religious orders. They were not hospitals in the modern sense. They were primarily institutions of care rather than cure, providing food, shelter, warmth, and spiritual support to the sick, the poor, and travelers. But they represent the beginnings of organized institutional medicine, and some of them provided genuine medical treatment alongside pastoral care.
So the medieval hospital was an institution of care in a period before cure was reliably possible.
Yes, and this function, providing dignified care for the sick even when cure was not available, is not a lesser function than cure. It is a different one, and one that the medieval world took seriously enough to build and sustain institutional infrastructure around. The Hôtel Dieu in Paris, founded in the 7th century and still operating today as a modern hospital, is the oldest continuously operating hospital in the world. Dental care in the medieval period is another area where the stereotype of universal neglect is significantly overstated. Archaeological evidence from medieval skeletal remains shows that dental decay was less prevalent in the medieval population than in the modern one, partly because sugar was expensive and rare, and partly because the medieval diet was lower in refined carbohydrates than the modern diet. Tooth extraction was practiced, tooth cleaning with twigs and abrasive powders was documented, and herbal preparations for toothache pain were common in medieval medical texts.
So medieval dental health was, in some respects, better than modern dental health, and medieval people did attempt to care for their teeth.
Yes. And this example illustrates a broader point about how material conditions shape health outcomes in ways that are independent of medical knowledge. Medieval people had worse medicine than modern people, but also had a diet, a lifestyle, and an environment that protected them from some of the specific health problems that modern conditions create. Comparing medieval and modern health requires holding both sets of conditions in view simultaneously, which the myth of the Dark Ages consistently fails to do.
Before we close tonight, let us take a brief pause and welcome Margaret Evernight. Margaret, for those who want to understand medieval medicine in the broader context of the history of medicine, where would you invite them to continue with?
Thank you, Clara. In this case, the most direct path is also the most important one. I would suggest beginning with The Greatest Benefit to Mankind by Roy Porter.
So this is a history of medicine from antiquity to the modern era that places the medieval period in its full context.
Porter's treatment of medieval medicine helps place the period in context, showing how inherited ancient theories, religious practice, herbal knowledge, surgery, and institutional care interacted in ways far more complex than the usual stereotypes suggest. The book is especially useful for understanding why medieval medicine was often limited, sometimes effective, and frequently misunderstood by later generations who needed it to be worse than it was.
Is it accessible to readers without a background in medical history?
Porter writes with exceptional clarity and range. The book is long and comprehensive, but each section stands on its own and can be read with profit by someone with no prior medical knowledge. He's particularly good at showing how medical ideas were shaped by the social and intellectual environments that produced them, which makes the book as much a cultural history as a medical one.
So it gives the reader medicine as it was actually practiced and understood in each period, rather than medicine as a simple progression toward modern knowledge.
Precisely, and for the medieval period specifically, Porter is an excellent corrective to the myths, presenting the actual range and complexity of medieval practice without either romanticizing it or dismissing it.
Thank you, Margaret. That is a thoughtful place to pause tonight.
Thank you, Clara. It was a pleasure.
The religious dimension of medieval healing is real and requires honest assessment. Relics, practices. They were central to how medieval people understood illness, recovery, and the relationship between the body and the divine. The temptation is to dismiss these practices as pure superstition. The more accurate assessment is more complicated. Pilgrimage provided exercise, clean water at many shrine sites, social support, and a framework of meaning that may have had genuine psychological and physiological benefits in some cases. The placebo effect, which modern medicine recognizes as real and measurable, operates through exactly the mechanisms that religious healing engaged: expectation, belief, and the social context of healing. Medieval people did not understand these mechanisms, but they were not responding to nothingness.
So religious healing was partly operating through real mechanisms, even when the theological explanation was incorrect.
Yes, and medieval practitioners were not unaware that some diseases resolved without treatment, and that some patients recovered while others did not. The problem was that without controlled observation, without the ability to distinguish between a recovery caused by the treatment and a recovery that would have occurred anyway, there was no reliable mechanism for separating effective treatments from ineffective ones. This is a fundamental methodological limitation of pre-scientific medicine, and it is a methodological problem, not an intelligence problem. Medieval surgery is another area where the popular image significantly underestimates what was actually practiced. Surgeons performed amputations, set fractures, treated wounds, removed bladder stones, and performed cataract surgery, all without anesthesia beyond alcohol and herbal sedatives, and all without understanding infection. The results were often poor and the mortality rates high, but the procedures themselves were not simply hopeful fumbling. Surgical texts from the medieval period show systematic knowledge of anatomy and technique, even if that knowledge was incomplete.
So medieval surgeons were operating within genuine technical traditions, not simply improvising.
Yes, battlefield surgery in particular developed practical expertise out of necessity. The Crusades, the 100 Years' War, and other sustained military conflicts created large numbers of injured men who required treatment, and a corresponding development of surgical knowledge. Surgeons who accompanied armies learned what worked and what did not through a volume of experience that civilian practice could not provide. The gap between the practical knowledge of experienced battlefield surgeons and the theoretical medicine of university-trained physicians was often considerable. The broader lesson of medieval medicine for how we think about the history of knowledge is significant. Medieval practitioners were not less intelligent than modern ones. They were operating with less information, with incorrect foundational theories, and without the methodological tools that would have allowed them to correct those theories through systematic observation. Progress in medicine required not only more observation, but better methods of observation, and those methods were developed over centuries of effort that the medieval period contributed to, even when it could not complete it.
So the medieval contribution to medicine was real even where the medicine itself was limited.
Yes, the preservation of ancient texts, the development of hospital institutions, the early public health responses to epidemic disease, the practical herbal and surgical knowledge accumulated through centuries of observation. These were contributions to a long project that the medieval period neither began nor completed. The myth of the Dark Ages suggests a void between the ancient world and the modern one. The history suggests a slow, uneven, and genuinely difficult accumulation of knowledge across a period that was neither uniformly dark nor uniformly enlightened. The modern relevance of debunking these myths is not merely academic. When we caricature the past as simply ignorant and superstitious, we make it harder to understand how knowledge actually develops, how incorrect theories can coexist with useful practices, and how intelligent people can reason carefully within frameworks that are fundamentally wrong. These are not only historical patterns, they are patterns that appear in every era, including our own, and recognizing them requires understanding how they worked before we were here to observe them thrive.
So the myth of the dark and dirty Middle Ages is itself a kind of intellectual failure that understanding medieval medicine can help correct.
Precisely. The people who invented the myth needed a backward past to define a progressive present. Do not need that myth. What we need is an accurate account of how people have always done their best with the tools available to them, and of how those tools have changed over time. Medieval medicine is a precise and instructive example of exactly that process.
Thank you for staying with us tonight. And thank you, Rowan, for guiding us through the bathhouses that existed, the honey that worked, the quarantine that was invented before anyone understood infection, and the long process of dismantling a myth that has done more damage than the medicine it describes.
Medieval medicine reminds us that being wrong about why something works does not always prevent it from working, and that the distance between ignorance and intelligence is usually smaller than we find comfortable to admit.
If this conversation stayed with you, you are welcome to like, comment, and subscribe. You will find other episodes here where history, ideas, and power are approached slowly. Until next time, stay with us.